The broadcast is now starting. All attendees are in listen-only mode.
Welcome to Breast Cancer Action's webinar, At Cancer's Margins, Sexual and Gender Marginality in Cancer Health and Experiences of Care. Thank you for joining us this morning. My name is Kira Jones, and I am the Communications Manager at Breast Cancer Action. Joining me on the webinar today will be Dr. Mary Kay Bryson, Director of the Cancer's Margins Project, and Liz Margulies, Founder and Executive Director of the National LGBT Cancer Network. A few quick announcements. Breast Cancer Action is fiercely independent and refuses corporate funding from any company that profits from or contributes to breast cancer, so we can always put women's health first. Our work is largely supported by individual donors like you. So please consider making a $25 donation today to support work like these educational webinars. Today's presentation will last about...
Slides. Slides and recording.
All right, hopefully the slides are, you can see this screen now. So today's presentation will last about 45 minutes. At any time during the webinar, you can ask a question by typing it into the question bar on your right-hand side of your screen, and we'll save time at the end of the webinar to answer as many questions as we can. Please note that everyone except for the presenters will be muted during the webinar to cut down on background noise so we can all hear well. And finally, we want you to get involved with Breast Cancer Action. This webinar is a great way to do that. So thanks for joining us, and stay tuned for other ways to get involved that we'll mention later on in the webinar. Today's webinar will cover the following. We'll start with an overview of Breast Cancer Action. Then I'll turn it over to our presenters who will cover the marginalization of gender and sexual minorities throughout their experiences as breast cancer patients, evidence and stories of gender and sexual minority breast cancer patients' experiences, and then the necessary accommodations that will move us closer to the equitable cancer care, and save lives. Then we'll touch on some additional resources and turn to Q&A with the presenters. A little bit about Breast Cancer Action. We were founded in 1990 by a group of women living with breast cancer who were frustrated with the lack of information about breast cancer. They founded Breast Cancer Action because they saw a need for a grassroots organization with a unique understanding of the political, economic, and social context of breast cancer. Our founders, only one of whom is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard to address this crisis. Breast Cancer Action is the only organization that addresses the breast cancer epidemic at the intersection of breast cancer, the environment, social justice, and feminism. Our mission is to achieve health justice for all women at risk of and living with breast cancer. We recognize here at Breast Cancer Action how issues of health and social justice are intertwined through the work we do and form a foundation for our core values around our work to address and end the breast cancer epidemic. That's why we made a clear commitment to social justice as a foundation of all our work. We know that breast cancer is a public health crisis and a social justice issue, and that women are not to blame for their breast cancer. That's why we focus on systemic solutions that get to the roots of the breast cancer epidemic. As the watchdog of the breast cancer movement, we educate, organize, and take action for systemic change in 3 distinct areas. The first is our work on breast cancer screening, diagnosis, and treatment, which examines the data from a patient perspective and includes breast cancer screening, healthcare access, drug and device approval, and demands more effective, less costly, and less toxic treatments. The next is our work around root causes of the breast cancer epidemic, which focuses on eliminating the involuntary exposures to hazardous and toxic chemicals that are present in all our daily lives and that put us at an increased risk of breast cancer. The last is pink ribbon marketing and culture, which often exploits a disease that devastates communities, misrepresents who is affected by breast cancer, and excludes and marginalizes women's diverse lived experiences of the disease. We address the true impact that breast cancer has on women's lives and their communities. In mainstream US culture, breasts are linked to femininity, sexuality, and attractiveness. As a result, breast cancer is a highly sexualized and gendered disease. As a feminist organization with roots in the women's health movement, we challenge the narrow definitions of femininity, womanhood, and sexuality that mainstream narratives about breast cancer impose on people at risk and living with the disease. We also recognize and honor the many ways people express their gender identity, including outside of the binary either or of man or woman. We work to challenge mainstream assumptions about gender and sexuality as they relate to breast cancer risk, diagnosis, and treatment in order to make room for people of all gender identities in the breast cancer movement. In our work for health justice, we strive to practice principled allyship by using the power and privilege we hold as an organization to build solidarity with communities who currently and or traditionally have had less access to power, information, and resources. And because our mission is to achieve health justice, and we know that achieving this requires each of us to be free from oppressions that prevent us all from living healthy lives in healthy communities, this webinar is a deeper dive into the marginalization of gender and sexual minorities and their experiences as breast cancer patients. So now I'd like to introduce our speakers in a little bit more depth. Dr. Mary Kay Bryson is the Senior Associate Dean in Administration, Faculty Affairs, and Administration, and Professor in the Department of Language and Literacy Education in the Faculty of Education at the University of British Columbia. Mary is a queer and non-binary breast and gynecological cancer ex-patient and director of the Cancer's Margins Project. This project is Canada's first nationally funded and national investigation of sexual and gender marginality and access to cancer knowledge, a project that answers the growing need in public health generally and breast and gynecologic care specifically for evidence that will assist healthcare providers in the design of culturally competent care. Liz Margulies is the founder and executive director of the National LGBT Cancer Network based in New York City. The network educates the LGBT community about their increased cancer risks and the importance of screening or early detection, trains healthcare providers to offer more culturally competent, safe, and welcoming care to LGBT patients, and advocates for LGBT inclusion in national cancer organizations, research, and the media. Now, I'll turn the time over to our presenters, beginning with Liz.
Hi and welcome. I am not seeing the place where I'm going to advance the slide.
You can go ahead and just use the arrow buttons.
I don't see an
on
arrow.
On your keyboard. I'm so sorry.
Oh, it worked. Good.
Yay.
So I'm going to talk about cancer in the LGBT community. And as I say, it's the same, only scarier for us. I'm going to start with a question. Is a lump a lump a lump, or does it matter who the lump spent Valentine's Day with? And I'm actually going to pause for a second because I want you to think about that. Okay, let me ask it differently. What if it's an ovarian lump and it's in a transgender man? Does it matter, or is the lump a lump a lump? And who does it matter to, besides obviously the person who has the cancer? I think, and this is the basis of my talk, that it matters absolutely to everybody, including the surgeon, even if it doesn't change the technique or the procedure that the surgeon does. It matters who the person's going home with. It matters who's going to be taking care of that person, what their home life is like, and what this means for them and their body. Sorry, there's a little delay here. I'm trying to move the slide. It's not moving. Let's try this way. No, the slide's not changing. Can you help me someone?
Yeah, absolutely. So,
Oh, I see. Wait, I see it. Let me try this. No, still not moving.
go ahead and you click on the screen, and then if you use the arrow button, it should allow you to advance.
It did. Okay, so thank you, and I'm sorry for the delay. So if I've convinced you at all that it does matter that providers know whose body the cancer occurs in, then we want to know how many people felt safe enough to come out, how many people were encouraged to bring their whole selves into treatment. And what you see here is the results of a national survey that my organization conducted of LGBT cancer survivors. And you see how few actually knew about their gender identity and or sexual orientation at the time of their diagnosis. I think we see that 88% of primary care physicians knew, because there's often time to choose a primary care physician, and you can change physicians. People go to their friends and say, who do you see? Do you like him or her? Maybe I'll try that person. But when someone gets a cancer diagnosis, there are fewer, if any, choices, and time is of the essence. And unfortunately, LGBT people often feel like they have to choose between the LGBT-friendly, less experienced person or the one with horrible bedside manner, but who's supposed to be, quote, the best, unquote. And if you feel like your life hangs in the balance, people are more likely to choose the person that they think is going to be the best provider. I'm trying here. Sorry, it's not changing again. There we go. So this shows how people came out to their providers, and you see how few were encouraged to come out. We're told that this is a safe place to bring your whole self. In fact, 58% had to bring the subject up themselves. What we know about people who do is that they are far more likely to be partnered. Single LGBT people are far less likely to come out. And then there's the sad rumor mill, which is 3%, where people were told by somebody else. I need to go back. There we go. This is the typical cancer continuum, and each phase is marked by different issues and usually addressed by different providers. So the mammogram technician and the radiologist pass the patient with the suspicious breast lump off to the surgeon, and then ultimately the oncologist. There might be social workers or palliative care providers might be involved as well. Oh my God. Can I just, Kira, can I have you advance my slides and I'll just say next slide, please? There we go. But I think to better understand the experience of LGBT people from risk to survivorship, we'd better to pull the arrows around until it formed a circle, because the issues faced by LGBT people are not discrete, but repeat themselves in each phase. And these issues are invisibility, lack of data, and discrimination. And those are not limited to one phase, but the risks follow people throughout. Next slide, please. And as you can see here, this is, if we need to have an arrow, this I think is the cancer continuum for LGBT people. Discrimination leads to individual behaviors that increase the risk for disease. And then instead of being followed by hypervigilance about screening and checkups, the opposite is true. The LGBT community has historically avoided the healthcare system due to costs and previous negative experiences with providers. Next slide, please. This is where cancer lives, at the intersection of these three issues. So I'm going to take them one at a time, and we'll start with discrimination. Next slide, please. Yes, there is LGBT discrimination even after marriage equality. In 2005, for example, Jews were the most targeted group, and LGBT people were second. LGBT people are twice as likely to be targeted as African Americans, and the rate of hate crimes against them has surpassed that of crimes against Jewish people. Next slide, please. But we are a diverse community, and discrimination is not distributed equally. All of us have multiple intersecting identities. And here you can see that trans women of color are at the greatest risk of being murdered, of being shot. Next slide, please. This addresses trans and gender nonconforming people who 70% of whom have experienced harassment in public bathrooms. Why is this a health problem? Because avoidance of bathroom use can lead to dehydration, urinary tract infections, and kidney stones. Next slide, please. What we've also found is that cancer can add to the discrimination in public bathrooms for many lesbian, bisexual women, or gender nonconforming people who choose to not undergo reconstruction following mastectomy, and who choose not to wear a wig if they have hair loss. Flat toppers, as some of them call themselves, may begin to experience discrimination in bathrooms. So my organization made these signs for multi-stall, single-sex bathrooms in cancer centers, and they are available as posters or stickers, and you can just contact me and I will send you as many as you'd like, but you can also download them yourself at www.bathroom.support. Next slide, please. So discrimination is not just unpleasant or unfair. It has real and serious health consequences. It compromises our immune system and raises our cortisol levels. And you can read these yourself, but each shows that discrimination leads very clearly and directly to health problems, mental health problems, serious physical health problems, and tobacco use. And this is true regardless of age, race, health histories. And the last one is particularly tragic, that showing that policy impacts our health. LGB, meaning they didn't have trans people who live in communities with high levels of anti-gay prejudice, died 12 years sooner. Discrimination takes 12 years off an LGBT life. Next slide, please. And trans people who have health insurance coverage or are brave enough to seek out healthcare aren't even out of the woods. Once they arrive at the doctor's office, 37% of patients report being harassed or disrespected. 3% even responded that they'd been physically assaulted at the doctor's office. No wonder we avoid the healthcare system. Next slide, please. So discrimination results in a number of individual behaviors that impact the health of LGBTQ people, such as drug and alcohol use, sexual health, obesity, etc. So recent studies have shown that bullying due to sexual orientation or gender nonconformity lead directly to tobacco use, the biggest preventable cause of cancer. So instead of blaming individuals for engaging in tobacco use or alcohol or drug use, please remember that these are unhealthy coping mechanisms for dealing with the stress and stigma of living as sexual and gender minorities. Lesbians are considered to have the greatest cluster of risk factors, as they call it, of any population, because as a group, lesbians use tobacco at higher rates, alcohol at higher rates, have a higher body mass index, high-fat diet, and are less likely to have had a biological child before age 30. So most of the individual behaviors here increase the risk for diseases, and most of these begin in childhood. Next slide, please. This is from a large Harris Interactive poll that found delaying and avoiding of the healthcare system by lesbians. And the important thing to note here is that this group that was interviewed were primarily white, middle class or above, and highly educated. So these are the more privileged group of lesbians, but this is true. Next slide, please. And studies have shown that trans people who delayed healthcare because of fear of discrimination had worse general health in the past month than those who didn't delay or delayed care for other reasons. discrimination equals illness. Next slide, please. So instead of hypervigilance, what we see is, even with the additional cancer risks, I mean, the data is mixed, but it looks like we have lower screening rates, especially for cervical cancer, but in many cases for mammograms as well. Next slide, please. So what happens once diagnosed with cancer? We find that, oh no, this is just about incidence. I'm sorry, I'm ahead of myself here. There is way too little research on this population, even though we have very high rates of breast cancer. And this is based on, that 8.4% is based on state data, because no national cancer registries collect information about gender identity or sexual orientation, which leaves us hidden in the data. So we know that we have increased risks. We know that we have lower screening rates, but we can't yet say anything definitive about incidence. The California Health Information Survey does ask, have you ever been diagnosed with cancer? And the rates are 50% higher than the general population, but we can't really extrapolate from California to the country, and certainly not to Canada. Next slide, please. This is the one I was jumping to. Once diagnosed with cancer, we fare worse. Now, this is about patient-centered care, which means that we look at how people feel about their health and their care rather than just looking at their blood work and their scans. And we have lower satisfaction and report poorer health following a diagnosis and treatment. Next slide, please. So back to that survey that my organization conducted, at the end of it, we asked people an open-ended question. If you were to give a class on LGBT cancer care, what would you want to say to the class? And over 80% of the people took the extra time to tell us how they felt about their cancer and being LGBT. And we divided them up and found that there were 6 themes. And the first is, which follows from everything I've said, that LGBT cancer patients start out very wary. After avoiding the healthcare system, people are thrown in without much thought because it feels life-threatening. But it doesn't mean that we are not afraid, and more afraid than heterosexual and cisgender people. Next slide, please. The second thing we found is that disclosure is related to safety. And you don't just come out once, you have to come out over and over and over again. And as people said, it was like a cost-benefit analysis. But each procedure that they had done had the anxiety of the procedure, and on top of that, a question about whether this was a time they should come out or not. So it's not just your doctor's appointments, but there are phlebotomists and MRI technicians and so many people. And everybody has to have this on top of their concerns about their health. Next slide, please. I do not have to tell this group that cancer care is gendered. People think that it's not. They think it's science and medicine, but it's not. It's very gendered, as you know, the whole pinking thing. And lesbians, so many lesbians wrote in their responses how much they hated the pinking of their cancer experience, because it's not a color that they chose to wear or have associated with them, aside from all the politics. Next slide, please. These are real logos and banners, and imagine a trans man with breast cancer or gender nonconforming person with breast or GYN cancer having to go into one of these places that says Women's Cancer Center. And what people told us is that, like the trans man who walked in with his girlfriend, everyone assumed she was the patient. This is not welcoming care. Next slide, please. I use this picture with permission, and many lesbians are rejecting reconstruction, and you can see the reasons on the left, but many lesbians told us, and gender nonconforming people, that they felt pressured to undergo reconstructive surgery, and they had to really fight to not have it. Next slide, please. Here again is the sticker or poster that you can have if you want. Next slide, please. LGBT patients rely on unique social networks that often incorporated friends, ex-partners, and what we call families of choice. And in mainstream society, the primary support systems are parents and partners. But people told us who was on their support team, and it included their dog and their therapist. And until the healthcare system can welcome our actual support systems into treatment and honor them as people who should be in for consultations and be able to weigh in on medical decision making, people are very alone. There is a myth that family rifts that might have been caused by somebody coming out will be healed after a cancer diagnosis. But one of the women in our survey wrote to say that she called her mother before her surgery, and her mother told her that she hoped she would die on the table, and she was sorry she was ever born. Next slide, please. I know that most providers are not very good at talking about sex after cancer treatment, but if the providers know anything, it's unlikely to be about LGBT sex. And we need to know, what does this mean? If they say no sex, does that mean no intercourse? What does it mean? And first of all, someone has to be out to get an answer to what they want. And secondly, they have to have a provider that knows the answer. And too often, that's not true. Next slide, please.
Thank
Next
you.
slide.
Oh, I believe, are you looking to go there, Liz?
I just still see let's talk sex.
Oh, looks like there's a little bit of a delay. It should be showing cancer's margins.
Okay, perfect. Now I see it.
Great.
So thank you very much. And now Dr. Bryson will take over.
Thanks, Liz. I'm the principal investigator of Cancer's Margins, which is Canada's first nationwide, nationally funded study of cancer and sexual and gender marginality, which is an extraordinary form of evidence of the lack of attention to this problem by state-funded organizations. Why Cancer's Margins? Why a national study of sexual and gender marginality and experiences of cancer health, decision-making, and support? I'm going to tell you about a perfect storm. I want you to visualize a random classroom of 40 people, 4 rows of about 10 people each. Generic statements about cancer prevalence tell you that about 1 in 2 persons will develop cancer in their lifetime. That's 2 of the 4 rows in our imaginary classroom. Cancer prevalence data indicate that about 1 in 4 will die of cancer. That's the whole back row. Except that, of course, in the case of sexual and gender minority populations, we have to factor in, as we've heard, LGBTQ and trans two-spirit population health disparities. We learned with HIV that ignorance kills. We're thinking about a classroom because we all need to be students of cancer health disparities. Now, we have a perfect storm, the likes of which the world has never seen. In this decade, across the globe, we have the largest ever population of people who identify as LGBTQ or as trans two-spirit. This group includes a huge age cohort, 50 plus, that is the most likely in the lifespan of breast cancer. This cohort is also unique in that we're old enough that within our lifetime, human rights violations against sexual and gender minorities have run the full gamut. When I was born, homosexual activity in Canada was illegal. In the US at present, LGBTQ and trans rights that some took for granted are being walked back, and discrimination in many places is no longer necessarily illegal. This burgeoning population has additional cancer risks, as we've heard, because of minority stress and other factors, and so the odds are likely higher than 1 in 2 or 1 in 4. And yet, cancer care systems are not even vaguely ready to meet this need. There are no standards of care for LGBTQ and trans cancer health and care, and none of the state-organized epidemiological surveillance systems include sexual orientation or gender identity anywhere in the world, including in Canada or the US. Next slide, please. Next slide. Liz Margolis has shared with you how, for LGBTQ and for trans people, there's a burden in healthcare settings of a lifetime of unequal risk. Regarding cancer health in particular, what data there are suggest that there are higher levels of risk combined with higher rates of prevalence, as well as lower rates of participation in screening and lower levels of patient satisfaction. All of these factors add up to higher levels of mortality and compromise quality of decision-making. Next slide. Let me tell you about the Cancer's Margins Project. We interviewed a very diverse group of 81 breast or gynecologic cancer patients who identify as members of sexual and/or gender minorities. We also interviewed members of cancer patient support networks and cancer care providers. In interviews with patients, we asked folks about experiences of care and decision-making and how they access knowledge and support. Next slide. The major goal for Cancer's Margins was to build intersectional evidence concerning identity and experiences of cancer health and care, and to document experiential evidence of how it matters that LGBTQ and trans two-spirit identities are multi-layered and intersectional. Next slide. The primary methodology of the Cancer's Margins Project is the extended individual interview, followed by a process where project participants returned to produce short documentaries. In Cancer's Margins, we prioritize experiential evidence. We see cancer patient stories as a necessary part of the contextual data that care providers and organizations need to tailor care to vulnerable communities. Next slide. The scope of Cancer's Margins data collection includes LGBTQ and trans two-spirit breast and gynecologic cancer patients in 5 Canadian provinces, as well as pilot data collected in the San Francisco Bay Area. Next slide. In talking about the findings today, I'm just going to focus primarily on cancer patient data and not support network members or care providers. Next slide. LGBTQ and trans two-spirit interviewees entered cancer care environments with a heightened awareness of the possibility of homophobia or transphobia. Queer and trans cancer patients experienced varying forms of discrimination or service refusal. Decisions about disclosing sexual or gender identity were linked with perceptions of safety and the possible impact of disclosure on quality of cancer care. Patients navigated what we are calling an awkward choreography of ill-fitting practices between sharing with care providers what matters about themselves and responding to forms and patient-provider scripts, like taking a history, that make sexual or gender identity invisible or that impose entirely normative and binary modes of thinking about sexuality or gender. Communication difficulties with cancer providers were most likely to occur related to patient decisions or values that contravened normative expectations of identity or of embodiment, exactly like what Liz was talking about in relation to the flat toppers and people choosing mastectomy and no reconstruction. Compounding marginalization then contributes to social isolation and barriers to accessing support. And we see this particularly in relation to people seeking culturally safe cancer support groups. Next slide. Another part of our findings pertain to queer and trans experiences of cancer surgeries and treatments. For queer Cancers Margins participants, trans narratives about surgeries inform decision-making about breast and gynecologic cancer surgeries. And what I'm talking about here is that mastectomy is also top surgery. And it's also the case that for some female-assigned trans people, hysterectomy is part of gender-affirming care. Hysterectomy is also part of treatment for some gynecologic cancers. This is a very significant overlap because this narrative, trans narratives, were part of the decision-making for many of our queer participants who did not themselves identify as trans. If you're a care provider, you need to be really familiar with what are the group-specific narratives that are an integral and valuable part of patient decision-making. Queer and trans participants diagnosed with breast cancer tended to select mastectomy without reconstruction, despite being pressured by care providers, as well as information found in leaflets and online, to elect reconstruction. However, and this is where you begin to see the value of qualitative population-based research, there were 3 subgroups of queer, lesbian, or bisexual participants who elected reconstruction. First, people who did not question surgeons' narratives linking mastectomy and reconstruction. And there's an issue here around the significance of geographic location to how likely it is that people are going to be participating in communities that involve a critical relationship with care provider instructions. And so our rural participants, for example, were more likely not to question surgeons' narratives. Secondly, participants diagnosed at an atypically young age or who were BRCA positive. And finally, interviewees who identified as femme and who prioritized breasts as integral to femininity. So for any of us raised with first or second wave feminist narratives that essentially devalue the notion that a woman could relate to her breasts as a significant part of her femininity, need to think about how for various groups, in fact, this is not a helpful narrative. For trans breast and gynecologic cancer patients, cancer surgery was experienced as gender-affirming healthcare. Gender-affirming healthcare needs, however, were not addressed by cancer care providers concurrently with cancer healthcare. And so in some cases, particularly for trans people living in urban areas who finally are able to access gender-affirming care, it was absolutely the case across the board that cancer care providers were not communicating in any kind of interdisciplinary team. And this becomes very important in relation to thinking about aspects of gender-affirming care like hormone administration. You can't just tell someone who's a cancer patient that they need to stop taking the hormones that are part of their gender-affirming care. We know from extensive research that gender-affirming care is crucial to quality of life and reducing some of the consequences of the lack of gender-affirming care, like suicidality and self-harm. And finally, our trans breast and gynecologic cancer patients encountered significant informational and institutional erasure. And it's not like invisibility is simply annoying or difficult. Invisibility also means that there's a lack of scientific evidence informing how care is being provided to trans cancer patients. And this is actually something that is highly significant and is an argument that, in my experience, cancer care organizations are starting to listen to. Part of Cancer's Margins involved bringing interviewees back for a process of their creating digital stories, working in tandem with experienced filmmakers to give us yet another way to learn from their experiences. And so we're going to see a short video here that really helps us to understand about the kinds of psychosocial complexities of being a queer parent, undergoing cancer treatment, and being in a relationship that tells us a lot about how important it is to design culturally safe and competent support. Next slide. Have you turned on the audio for that?
Are you hearing audio?
Nope.
2 weeks after my partner Deborah finished her mat leave, I was diagnosed with breast cancer. Our daughter was a year old.
The cancer was a curveball that we just were so not ready for, and it really, it kind of drove a wedge between us.
I was trying to cope with the physical effects of the treatment and also coming to terms with the emotional part of being a new parent with cancer. I wanted to do everything I could to be around as long as possible for my daughter. I was focused on these big picture things, and I guess I thought, well, my partner is a healthy adult and she can take care of herself.
And I just went into some kind of like weird husband mode where I felt like, and so I worked full time though. And now that I think about it, I might have used part of it as a kind of a strategy to kind of just to keep busy and to also feel like a sense of control, maybe like home life was a little out of control.
The hardest part for me was feeling Deborah's anger at me. It was really upsetting to have to face that. I had so little energy to give her, and I didn't realize what was going on, why she was so angry at me.
I think I was angry a lot. Angry at our situation, angry that, this had happened, and sometimes angry even at Linda about the way that she was coping, which was to sort of retreat a lot.
Then one day she finally broke down and cried, and we realized that she was really scared that I was going to die, that she would lose me. We hadn't talked about that very much. We were so focused on the day-to-day coping. It made such a difference to realize that there was fear behind that anger. And I think that was the start of us becoming a couple again, of having some common ground. We had planned a trip to Hawaii for the end of my chemo so I could rest up before the radiation. When we were in crisis, I thought maybe we should cancel the trip. It was scary to think about being so far away from our friends and support when we were barely able to speak to each other. But we went anyway. We stayed on the north shore of Maui near the cane fields. The whole area was infested with flying cockroaches. We were so stressed out every evening as the sun went down because that's when they came out. They were all over the cottage we were staying in. We both have a phobia about cockroaches, but my way of coping was to try and kill them all. I'd get out the squirt bottle and the fly swatter and shut myself in rooms with them just so I could kill them. After a week, we were so relieved to move to another part of the island. Then one night, a huge poisonous centipede crawled right past our daughter who was playing on the floor. I froze, but Deborah jumped into action. She grabbed the centipede with kitchen tongs and threw it down the garburator. I remember one especially hard day in Hawaii. I went down to the ocean and I just floated there thinking, okay, I'm going to let go of the hurt and anger right here so I can love Deborah again. I'm so grateful that she must have done that too.
Seem so wise, seem so free. Heaven above, the sea below. And I lift white whale on the coast.
So the next Cancer's Margins digital story that I'm going to share with you provides a very compelling account of the total lack of coordination of gender-affirming care for trans and two-spirit cancer patients and cancer care that's medically and culturally competent. Next slide.
I'm neither fish nor fowl, was the answer I gave the gender therapist when he asked me. Why are you here? And what does that mean, he asked. I said I didn't know for sure, but it was a family expression that was used when someone didn't fit. I had been struggling with depression and a deep, deep secret. Now, the genie was out of the bottle. I was certifiable as having gender dysphoria. I knew what I wanted. I wanted chest surgery. And my first indications were that this might take a year to happen. I was so excited to open up my life, to live again. With all this good news, the apparently minor health concern that popped up 2 months later was no biggie. Until my GP sent me for an abdominal ultrasound and called me at work. Come down and see me today and bring your partner. You know, this is not good. You have not won the lottery. My GP told me, you have a large, complex mass in your abdomen. I've got you an appointment with a gynecological surgeon in 9 days. What I heard when I met with the gynecological surgeon was, here are the options, using her standard female anatomy handout. Which parts come out in which order. She showed me a 3D representation of the large, complex mass. She said it looks like a tumor, but it could be cysts. She says there's only a 10% chance of it being cysts, but I didn't hear that. What I heard was free hysterectomy, free bottom surgery with 8 weeks of recovery. I could put my life on pause for 8 weeks and then look forward to the chest surgery. When I wake up from the bottom surgery, my heart tells me it's all gone. I feel great. A week later, I'm home from the hospital, sitting in my favorite recliner. My endorphins have kicked in and I barely need any pain meds. That's how good I feel. Then the phone rings. It's the gynecological surgeon. I have your pathology report. It was a high-grade carcinoma, stage 1, grade 3 on the right ovary. Cancer. That's when it really hits me. I have to think about cancer, mortality, the whole 9 yards. What do I do next? 6 cycles of chemo brain, nausea, neuropathy, infections. What kept me going was my future in a body that matches who I am. When the chemo's done, everyone wants to celebrate. It's done, it's done. I feel like shit. And here's the worst part. I still have to wait for my blood test to be okay, to get the green light for the chest surgery wait list. That's a 3 to 6 month wait. More waiting. But then I get the phone call, a good phone call for once. There's a cancellation. Can you come next week? Yes! In a 12-month period, I got my cancer diagnosis, my hysterectomy, my chest surgery, and my real life begins. I am neither fish nor fowl, but I'm proud of it. It's who I am.
Next slide. So in conclusion then, we need to think about next steps. Next slide. Today we've talked about minority stress and described how for LGBTQ and for trans and two-spirit people, there's a burden in cancer health and care settings of a lifetime of unequal risk. So let's review what would be immediate implications of our research that cancer care organizations could take steps to implement right away. Medically and culturally competent care is ethical care and will improve cancer care and save lives. Care that is culturally appropriate and medically competent needs to be evidence-based. Cancer care organizations need to address the issues of prevalence, risk, and minority stress that we've talked about today. Informational and institutional erasure regarding populations with cancer health and prevalence disparities has deadly consequences. There's no monolithic LGBT or trans identity, and paying attention to sexual and gender marginality has to be based on an intersectional model of identity complexity, of identity fluidity. Cancer care and gender-affirming care need to be coordinated with a particular focus on hormone administration and cancer care, but also on the significance of cancer surgeries to gender identity. Given the known burden of minority stress on queer and trans patients, particular attention needs to be paid to tailoring appropriate cancer supports to assure safety and respect for human rights in cancer care. Thank you. I think we have time now for some questions.
Yes, thank you so much, Dr. Bryson and Liz, for sharing your wealth of information with us today. We'll open up to questions in just a moment, but before we do, I want to just talk a little bit more about how you can get involved with Breast Cancer Action. If you're interested, you can become a member by signing up for our news and action alert emails to keep up to date with our issues. Join us on Facebook or Twitter. You can also get involved by telling your friends, coworkers, and family about this webinar and how they can take action. We record all our webinars and make them available on our website. And lastly, you can donate to support our education and advocacy work. As we mentioned in the beginning, Breast Cancer Action relies on your support to make these webinars possible. Again, a huge thank you to Dr. Bryson and Liz for their presentations today. Now, I want to turn to some of the questions that we have had come in. And as I do that, if other questions are percolating, feel free to just jot those into the questions box. The first one is, let's see, many people, including gender or sexual majorities, as well as minorities, describe physical and psychological and sexual impacts of a cancer diagnosis. We have heard about some people whose coming out process is tied to their cancer experience. What do you know about shifting and evolving gender and sexual identities in response to the experiences of being diagnosed with and treated for breast cancer? Either Dr. Bryson or Liz, whoever wants to take that.
Liz, do you want to take that on?
You can.
I actually don't understand the question. So maybe because it's so long, maybe start at the end. What's the last part of it?
Yeah.
I don't understand the connection between coming out and then the last part of the question.
Yeah, what do you know about shifting and evolving gender and sexual identities in response to the experience of being diagnosed with
Oh,
for breast
okay, sure. I can say something about that.
Great.
I'm going to talk about two kinds of narratives that I've heard in interviews. The first narrative involves people who very consciously describe themselves as gender nonconforming, and to our question, we ask everyone, is there any part of your gender identity that you would describe within some kind of trans umbrella? And they're very emphatic to say no. They also are really clear about how their gender identity is not, say, normative. And so one example would be a person who has a very masculine of center gender identity. For those folks, the interviews made it really clear that some of the consequences, let's say you have a very masculine of center identity and you have a mastectomy. Well, because of the issue of the overlaps that I was talking about concerning trans narratives that circulate within queer communities, so not necessarily people who identify as trans, as soon as that person who's masculine of center has a mastectomy, then they will encounter a lot of folks in their community who assume that they're transitioning, who assume that their mastectomy is top surgery. And so as a consequence of that overlap, they have to deal with the impositions that people make, I'm sure with a very positive intent, that their gender identity is shifting in a direction that's not of their own choosing. So for many of our interviewees, there were gender implications of breast and gynecologic cancer treatment that they then had to negotiate, because of course your gender identity and your expression is both your own experience and how people take up that expression. So that was one subgroup of participants for whom there were some unexpected and unwanted consequences of cancer surgeries vis-a-vis their gender expression. And then, of course, there were the participants who did not necessarily in a completely black and white fashion identify as trans, for whom then subsequent, say, to mastectomy surgery, they were very aware of experiencing their body and their gender identity in a way that shifted for them. And so then perhaps that subgroup of cancer patients were more likely to identify as non-binary. And at this point, non-binary is frequently located somewhere on the trans spectrum. And so there were also that subgroup. So there were many different kinds of experiences of the impacts of cancer surgeries and treatments on people's felt sense of gender identity, which of course is always already also social and cultural, and is being taken up by people in ways that were expected and unexpected.
Thank you, Dr. Bryson. One question that kind of builds on that, and I think you may have spoken to this a little bit, but if you can expand a little more. One question says, I'm shocked to hear Mary say that mastectomy is also top surgery. In fact, mastectomy involves removing all breast tissue, including nipples and even thinning skin, whereas top surgery is removing breasts but leaving enough tissue to cosmetically look like a male chest. The physical and cosmetic result is very different, and I think these two surgeries should not be conflated because it misrepresents mastectomy. Can you speak to that piece a little bit more, Dr. Bryson?
Sure. I think from a technical surgical point of view, that's probably a very helpful clarification. I don't think that regular people necessarily make those kinds of fine distinctions. And so for many of our gender nonconforming or trans interviewees, mastectomy was top surgery. And so for those participants, as you could see in the digital story that we shared with you today, the overlap was particularly poignant. And so I think that there's a technical surgical distinction that we could make, but I don't think that's really at the level where people are interpreting what's happening to their body. And of course, it's a helpful distinction also in the sense that for gender nonconforming cancer patients who want top surgery, at this point, finally, surgeons, particularly in the US, but to some extent now also in Canada, have become much more sophisticated when it comes to, say, nipple sparing techniques. And nipples are placed in a different location in the body as a function of gender identity. And so cancer surgeons should be aware of this, because in those cases where mastectomy is being carried out for reasons of a breast cancer diagnosis, in the case of trans or gender nonconforming patients for whom nipples can be spared, There should be a discussion then as to the location of the nipples so that the end result is actually chest reconstruction, which would be a significant part of how satisfying the outcome would be for a female assigned person who identifies as trans.
Thank you. And so we're just about out of time, but I feel like I'd like to ask this question that's given to Liz. Liz, you talked about the ways that invisibility, lack of data, and discrimination produce worse cancer care and outcomes. Can you elaborate on what you mean by invisibility above and beyond lack of data?
I think that many of the people in our survey leapt back into the closet for their cancer care, even if they had been out for the rest of their lives. As one person said, the only good cancer hospital by me was a Catholic hospital, and I feared that the homophobic surgeon would leave a lesion behind, or the homophobic nurse would not give me pain medication when I needed it. And I think that if you withhold, and I'm not questioning their decision to, but I think if you withhold who you really are, you can't, that means that a big piece of your life is invisible. People told us that they never had their partners come to the hospital or appointments with them for fear of coming out. And that invisibility takes a terrible toll on people.
Thanks, Liz. Well, I think we're going to have to wrap up there. I want to thank you so much for all your thoughtful questions and comments. And if we didn't answer your question today, or if you think of one later that you'd like to ask, please follow up with us at info@bcaction.org. Thank you so much for your time and your attention, and please watch for an email from us with a short survey. We'd love to hear your feedback on this webinar, which helps us make this program better and better. And again, last but not least, thank you again, a huge thank you to our presenters, Dr. Bryson and Liz Margulies, and everyone. Have a great rest of your day.